Hi guys, welcome to Easy Medicine. The topic for discussion today is hypothyroidism. What is hypothyroidism? It is nothing but a condition where the thyroid gland is not able to produce sufficient levels of T3 and T4. Let's look at the hypothalamo-pituitary thyroid axis for once. The hypothalamus produces thyrotropin releasing hormone, and under its influence, the pituitary gland produces thyroid stimulating hormone. And under its influence, the thyroid gland produces T3 and T4. This constitutes the trophic pathway, and this T3 and T4 will have inhibitory action on the pituitary as well as the hypothalamus. That constitutes the negative feedback pathway. This you have to keep in mind while we understand the investigations and how we proceed with them. What are the causes of hypothyroidism? The hypothyroidism can result from a thyroid cause or a pituitary cause. When it results from a thyroid cause, we call it the primary hypothyroidism. When it arises from the pituitary cause, we call it the secondary hypothyroidism. There are various causes which can result in hypopituitarism that can further result in secondary hypothyroidism. We are not going into that now. Our primary focus is on the primary hypothyroidism. The common causes of primary hypothyroidism are the Hashimoto's thyroiditis, iodine deficiency, radiation, and postoperative, some drugs like lithium and the spironolactone. The Hashimoto's thyroiditis is the most common cause of primary hypothyroidism worldwide, and iodine deficiency is the most common cause of primary hypothyroidism in developing countries. Let's look at the Hashimoto's thyroiditis proper. So it is the most common cause of primary hypothyroidism, and it is an autoimmune process. The incidence is high in women, and it is approximately 4 per 1,000 women, and the peak age is 60 years of age. Let's look at the pathogenesis of the Hashimoto's thyroiditis. Here comes the T cells as well as the B cells, and the B cells are producing the antibodies. The T cells and the B cells will have three target antigens here: thyroid peroxidase, the TSH receptor, and the thyroglobulin. The T cells bind the target antigens and the antibodies also bind the target antigens. These antibodies will block the TSH receptor so that the TSH cannot bind the TSH receptor. They are called as TSH receptor blocking antibodies. The antibodies which bind to the TSH receptor can be of two types. One is the TSH receptor stimulating antibodies. Other one is the TSH receptor blocking antibodies or the TSH receptor inhibitory antibodies. The word itself tells you when there are stimulatory antibodies, there is increased production of T3 and T4 that will result in hyperthyroidism. These antibodies are predominantly seen in Graves' disease. And these inhibitory antibodies will result in hypothyroidism, predominantly seen in Hashimoto's thyroiditis. But keep in mind that both can be seen in Hashimoto's thyroiditis. This is a normal thyroid. Okay, when there is infiltration of the T cells and the B cells, the thyroid gland gets swollen, and the patients present to you with local symptoms like pain and the goitrogenic swelling. After the acute inflammation is completely burnt out, the colloid and the thyroid follicle are depleted and it is replaced by fibrosis, because of which the thyroid gland will get shrunken. This is the stage where the patient will have obvious hypothyroidism. When there is acute inflammation, the patient can also have transient hyperthyroidism. We call it the hashitoxicosis. Let's look at the clinical features. The thyroid hormones themselves have a lot of varied functions, and hence, when they are deficient, we'll have varied manifestations as well. Okay, let's look at them organ wise. What happens with the cardiovascular system? There is peripheral vasoconstriction because of hypothyroidism, and hence there is increased systemic vascular resistance, because of which the patient will have hypertension, which is primarily diastolic, because diastolic hypertension is the one which is dependent on systemic vascular resistance. And there is reduced chronotropicity of the heart as well. Because of that, the patient will have bradycardia. And there is third spacing in the hypothyroidism. What is third spacing? The fluid gets deposited in the pleura, pericardium, and the peritoneal spaces. One such space is the pericardial space where the fluid gets deposited. That results in pericardial effusion. What happens with the lung? There is something called as glycosaminoglycans or the mucopolysaccharides which deposit in the upper airway here. That results in obstructive sleep apnea. This deposition of glycosaminoglycans can be seen in various parts of the body in hypothyroidism that will result in varied manifestations. We'll subsequently look at them. The property of the glycosaminoglycans is to trap the water. Okay, when they trap water, they'll put some pressure in the surrounding tissues, and that will result in various clinical manifestations. Because of third spacing, again, the patient will have pleural effusion. Let's look at the manifestations of GIT. The patient will have constipation because the bowel motility is slowed down, and the patient will have decreased metabolic rate. Because of that, the patient will have reduced energy consumption and further weight gain and obesity. The point to be noted is that the appetite is also reduced in hypothyroidism. Despite having a low appetite, the weight gain is quite common. In regard to the nervous system, the hypothyroidism can have the effect on both peripheral nervous system as well as the central nervous system. In the peripheral nervous system, again, because of the deposition of glycosaminoglycans at some tight spaces like the tunnels where the tendons and the nerves are passing through, there is increased pressure in those enclosed areas, and that will result in nerve entrapment. An example is carpal tunnel syndrome. One of the manifestations is that when we test for the deep tendon reflexes, there is slow relaxation of tendon reflexes that is called as pseudomyotonia. When you talk about the effect on central nervous system, the patient will have the impairment of memory and the concentration. What happens to the menstrual system? Oligomenorrhea and the amenorrhea are commonest manifestations, but at the earlier stages of the hypothyroidism, the patient can have menorrhagia, and there is reduced fertility as well. And if the patient is pregnant and she is having chronic hypothyroidism, the patient can also have miscarriage. Let's look at the skin manifestations. The outermost layer of the skin, which is the stratum corneum, is hyperkeratosed. Because of that, the patient will have a dry skin. And then there is deposition of glycosaminoglycans in the skin. They will further trap water. Because of that, the patient will have non-pitting edema again. We call it the myxedema. The patient can also have pallor. Nail and hair are also involved. So the poor nail growth, and the hair becomes brittle and sparse. Because of that, the patient will also have alopecia subsequently. What happens to ear? The patient will have conductive deafness or the sensorineural hearing loss. The two terms that you have to remember in relation to Hashimoto's thyroiditis are the Hashimoto's encephalopathy and hashitoxicosis. What is Hashimoto's encephalopathy? This encephalopathy is not because of hypothyroidism per se, but it is supposed to be because of the antibodies in the Hashimoto's thyroiditis. What is the presentation? The patient will have stroke-like focal deficits, and some patients can have cognitive decline and dementia. And the point to be noted here is this encephalopathy is steroid responsive and it is completely reversible. Another term is hashitoxicosis. We have encountered a transient hyperthyroidism when the patient is having acute inflammation. That we call it as the hashitoxicosis. This results because of the thyroid follicular disruption and abnormal release of T3 and T4 during the times of inflammation. This autoimmune disorder is commonly associated with various other autoimmune disorders as well. Just to name them, some of them are vitiligo, pernicious anemia, Addison's disease, type 1 diabetes mellitus, rheumatoid arthritis, systemic lupus erythematosus, and myasthenia gravis. Evaluation pattern. So this is a pathway that we already know. Let's suppose there is a pathology at the level of the thyroid gland. So T3 and T4 decreases, and because of the negative feedback pathway, the TSH increases. This is primary hypothyroidism. Let's suppose there is a pathology at the pituitary gland. Because of that, TSH will become low, and because of that, T3 and T4 will also be low. Then it is secondary hypothyroidism. Now let's go to the investigations. The first test that we do is TSH. TSH can be elevated or it can be normal or low. If the TSH is elevated, the next investigation that we have to look at is free T4 levels. Again, the free T4 levels can be normal or low. When it is normal, we call it the mild hypothyroidism and sometimes subclinical hypothyroidism. If the patient is having mild hypothyroidism, we are in question whether to treat the patient or not. So let's do the TPO antibodies. If the patient is symptomatic or if the patient is having TPO antibodies, then you will have to treat the patient with levothyroxine. Or if the TPO antibodies are negative and if the patient is asymptomatic, you can follow up annually. What if the free T4 is low? Then the patient is having symptomatic primary hypothyroidism. And again, we have to do TPO antibodies. If the TPO antibodies are positive, it suggests the autoimmune pathology, and again, we have to treat the patient. If the TPO antibodies are negative, still, since the patient is symptomatic and the patient is having primary hypothyroidism, you have to treat the patient, but you have to rule out the cause for it. So when the TSH level is normal or low, again look at free T4 levels. If the free T4 levels are low, the commonest cause could be the secondary hypothyroidism. But along with that, we may also have to rule out some other causes like drug effects, sick thyroid syndrome. And for evaluation of the secondary hypothyroidism, evaluate the anterior pituitary function. And you can also do MRI brain. Now that we reached different causes of hypothyroidism, let's look at the treatment part. The first question that arises is whether to treat the patient with T3 or T4. The T3 has a short half-life of 3 to 4 hours and T4 has a half-life of 3 to 4 days. T3 is the active form and the T4 is the pro form and the storage form. Okay, so it is feasible to give T4 since the T4 is an oral form as well, whereas T3 is an intravenous form. So when we give T4, whenever it is required, it gets converted to the active form, that is T3 in the body, and gets utilized. So how do we treat? The T4 is given at a dose of 1.6 microgram per kg per day, and it accounts for about 100 to 150 micrograms per day. But this is the dose that we have to give if the patient is not producing any thyroid hormone. But any case of hypothyroid patient, the patient will have reduced levels of thyroxine hormone, but not zero levels. That's why the dosage should be started at different levels for different patients. If the patient is less than 60 years of age and the patient is not having any heart disease, we may start the patient at a dose of 50 to 100 micrograms per day. And if the patient is elderly and having a coronary artery disease, we can start at a lower dose of 12.5 to 25 micrograms per day. Okay. And pregnancy is a state where the thyroid hormone requirement is high. That's why if the patient is previously taking 7 doses in a week, the patient may require 9 doses per week. And the target TSH should be less than 2.5. What's the goal of the treatment here? Our goal is to normalize the TSH, but how long does it take? It will take approximately 3 to 4 months. How long does the clinical features to disappear? It will take 3 to 6 months after the TSH normalization. And how do we adjust the dose? At every follow-up, we'll adjust the dose by 12.5 to 25 micrograms. So what happens when the patient misses a dose? There is no worries. The patient may be asked to take 2 doses the next day. When to start levothyroxine in subclinical hypothyroidism? There are certain conditions. Not every case we have seen in the chart where a patient of mild hypothyroidism may be annually followed up if the patient does not develop any clinical symptoms or if the patient is TPO antibodies negative. The conditions where you start levothyroxine even if the patient is having subclinical hypothyroidism are when the TSH is more than 10 or if the patient is symptomatic or if the patient is a pregnant female and if the TPO antibodies are positive if the patient is having heart disease. In all these conditions, if the patient is a subclinical hypothyroid, we are supposed to start thyroxine at a lower dose of 25 to 50 micrograms per day. If the patient is a known case of chronic hypothyroidism and he or she is not being treated, the patient may land up in a severe form of hypothyroidism, which is also an acute emergency called as myxedema coma. What are the risk factors for the myxedema coma? Mostly the patient will be in ICU with various comorbidities. What are those risk factors? The patient can have congestive heart failure, or a myocardial infarction, pneumonia, or sepsis, gastrointestinal bleeding, cerebrovascular accidents, and the patient may be having effects on such drugs like sedatives, antidepressants, and anesthetics. Let's look at the features. The features are nothing but extreme variants of a case of hypothyroidism. The patient can have bradycardia, hypoventilation, reduced levels of consciousness, or the patient can also have seizures, hypothermia, hypoglycemia, and hyponatremia. Hypothermia is because of reduced vessel metabolic rate. Hyponatremia is because of increased fluid overload. How do we treat a patient of myxedema coma? We have to correct the T3 and T4 rapidly. That's why we'll give intravenous forms, or we can also give through the nasogastric tube. The dose of T4 is approximately 200 to 400 micrograms as the loading dose, followed by 1.6 microgram per kg per oral once daily. Along with that, we also have to supplement the patient with intravenous hydrocortisone at a dose of 50 micrograms 4 times a day. Why do we give hydrocortisone? Because there may be coexistent adrenal insufficiency as well in such patients. And we have to give hypertonic fluids. Why not the routine hypotonic fluids? Because the patient is already having fluid retention. The hypotonic fluids will exacerbate the fluid retention. That's why it is preferable to give the hypotonic fluids like dextrose and 3% NaCl. And we have to treat the cause as well. And for that, you need to give the supportive therapy. Thank you.